If everyone can find their seats, we're going to start the next panel. All right, we're ready to begin our next panel. We will hear from those who work to reduce the demand that we are seeing here in this country. We recognize that this must be a dual-pronged approach of targeting both the supply as well as the demand in order to stem the tide of overdose deaths in this country. The moderator of this panel is Beth Williams, Assistant Attorney General of the Office of Legal Policy. Beth Williams was sworn in as Assistant Attorney General on August 21, 2017, after unanimous confirmation by the Senate. As Assistant Attorney General of the Office of Legal Policy, she serves as the primary policy advisor to the Attorney General and Deputy Attorney General, and as the Chief Regulatory Officer for the department. Under AAG Williams' leadership, OLP has been a crucial part of the department's policy and regulatory work to curb the drug epidemic. Please join me in welcoming AAG Beth Williams and our second panel.
Thank you, Amanda, and thank you very much for organizing such a terrific event. We're really happy to be here. And thanks to everyone in the audience, all of you who work to prosecute these cases and bring the drug dealers to justice, and also for being here today. In the last panel, we discussed efforts to reduce the supply of drugs in our communities. And in this panel, we're going to address the impacts of the drug epidemic, emerging trends, and prevention and treatment. And I'm pleased to share this stage with some of the foremost experts on these topics. The first to my left is the Honorable James Carroll, Director of the Office of National Drug Control Policy. ONDCP, as it is known, establishes and leads national drug control policy across the administration. Prior to joining ONDCP, Director Carroll served as Assistant to the President and Deputy Chief of Staff at the White House. Previously, Director Carroll served as General Counsel of the Office of Management and Budget and as Deputy Assistant and Senior Counsel to the President. Director Carroll began his career as a state prosecutor. Next, we have Dr. Eleanor McCants-Katz, who is the HHS Assistant Secretary for Mental Health and Substance Abuse. Assistant Secretary McCants-Katz leads the Substance Abuse and Mental Health Services Administration, or SAMHSA. She's an addiction psychiatrist and clinical researcher with over 30 years of experience specializing in the treatment of substance use disorders, particularly opioid use disorders. So thank you for being here. Our third panelist is the Honorable Christina Nolan, the U.S. Attorney for the District of Vermont. U.S. Attorney Nolan, who is a Vermont native, served as an Assistant U.S. Attorney in the District of Vermont from 2010 to 2017 before her unanimous confirmation as U.S. Attorney in 2017. As a member of the Attorney General's Advisory Committee, U.S. Attorney Nolan has been a leader on opioid and drug issues across the U.S. Attorney community. In the last year, her office, working with federal, state, and local law enforcement, has conducted a number of successful narcotics enforcement surges throughout Vermont. Last but not least is Judge Katie Sullivan, Principal Deputy Assistant Attorney General for the Office of Justice Programs at the Department of Justice. Judge Sullivan leads OJP, the Department of Justice's principal funding, research, and statistical component, overseeing more than $5 billion in grants, including $333 million in funding to support the fight against the opioid epidemic and addiction crisis in fiscal year 2019. Judge Sullivan currently also serves as Vice Chair of the President's Commission on Law Enforcement and the Administration of Justice. She previously served on the White House Domestic Policy Council and is Acting Director of the Justice Department's Office on Violence Against Women. Before joining the Department of Justice, Judge Sullivan served as a Colorado State Trial Court judge, where she implemented and presided over a drug court and a DUI court. We're very happy to have all of our panelists here today, so thank you for being here. I'd like to start by looking at the harm caused by this epidemic and then some current trends that you're seeing. Ellie, can you please give us a brief overview of the impact of the opioid crisis from your perspective and from the perspective of HHS?
Sure. So I think I'll talk about that from the perspective of what a person with opiate addiction looks like when we see them. Opioids are drugs that produce what we call physical dependence in the body. And what that means is that as the person uses more opioids, they have to continue to use more opioids to get the same effect. If they don't get those opioids, they go into a painful withdrawal syndrome. They get chills, they feel miserable physically, they have nausea, vomiting, terrible muscle and joint aches, and that drives the use of the drug. And so they have to keep using the drug to, what a lot of people will say, feel normal. So that causes them to just, their life revolves around getting, using, being intoxicated, and starting to withdraw from the drug and then looking for that next dose. What that means is they neglect themselves, their own health, they'll neglect their families, their children, they'll leave their employment, they become very financially distressed and often will engage in criminal activities to get the resources to get that drug. And multiply that by 2 million, because that's how many people in this country have opioid addiction. And that's why we have such terrible problems in our communities. I think it's easy to see from that how that would start to tear apart the social fabric of our nation. And that's what we face with opioid addiction.
That's really helpful. I think a lot of people don't think about the actual physiological response and what's part of what's driving this. Christina, what have you seen in Vermont, in your district? I know in New England has been an especially hard-hit area. What have you been seeing?
Yeah, I think, can everyone raise your hand if you can't hear me? I think what's going on in Vermont, it mirrors what's going on in the rest of the nation in a lot of ways, but on a micro scale because we're only 625,000 people up in Little Vermont. So that in the nation there were more than 67,000 overdose deaths. Most of those in the last year for which we have full data, most of those attributable to opioids. That is, of course, more deaths than in the peak years in America for guns, car crashes, AIDS, more deaths in the entire Vietnam War. It's staggering when you think about it that way. In Little Vermont, there were 110 overdose deaths in 2018, and their preliminary data shows that in 2019 we may see a reduction to something like 96, but we're not sure that those numbers are going to hold yet. We hope they do. So that's, if I have my math right, 14 people. That's huge to me, but we have a long way to go. The biggest problem we see, bar none, is fentanyl. The vast majority of our overdose deaths involve fentanyl. In fact, we very rarely, if ever, seize heroin anymore that doesn't have fentanyl in it. So it's basically all fentanyl, our opioid problem. And of course, synthetic opioids are responsible for fentanyl and other synthetic opioids are responsible for about 28,000 deaths a year in the country. Maybe you all know this, but I just think it bears repeating. Fentanyl analogs, these are terrifying narcotics. They are more like ricin and arsenic and straight poison than other drugs. Fentanyl is 50 times more potent than heroin. It is 100 times more potent than morphine. Fentanyl analogs can be 100 times more potent than fentanyl itself. And thank goodness those are still illegal in this country. And aren't we grateful for the department and its leadership in making sure that these fentanyl analogs continue to be illegal drugs in this country like they are in China. And thanks to everyone in this room who worked to make that happen. 2 milligrams, clapping would be, but we only have so much. Yeah.
Yay.
I'd rather have it be permanent, but we'll take the temporary extension because lives will be saved for that period of time. 2 milligrams of fentanyl, forget about analogs, but fentanyl itself will kill the average adult. That is the size of about 2 grains of salt. In Vermont, as in much of the nation, fentanyl is being pressed into pill form. We've had huge seizures of counterfeit pills in Vermont, so it's being pressed into pill form but made to look like less potent opioids like Percocet. We've had those seizures in Vermont, and it's also another frightening way that this is being marketed and distributed is it's being laced into other drugs like powder cocaine. So when this happens, it's a very monstrous strategy. It's a very monstrous way to make money. But what happens is people who don't think they're getting fentanyl, they think they're getting a less potent substance, are using it, and they're overdosing with no Narcan on hand because they don't expect to be overdosing. In Vermont, 1/3 of our opioid overdose deaths in 2018 also involved cocaine, and that is in part attributable to this lacing strategy. So that's probably enough out of me for the moment. But
No,
that's an overview of our problem.
That's really helpful. Jim, for those members of the audience who may not be as familiar with ONDCP, can you tell us how ONDCP fits into the landscape and what trends that you're seeing from the White House perspective?
As the director of the Office of White House National Drug Control Policy, my title is also known as the U.S. Drug Czar, and I'm charged with the responsibility of being the principal drug advisor to the president. In order to do that, I talk with so many of you all, and I'm out on the road frequently, and that's where I've had the opportunity to meet with you all, is by being in your districts and finding out what's happening there on the road. But it's also a responsibility to oversee the $36 billion that the U.S. government spends on this issue across the three main lines of effort. You heard Udom Dillon and, of course, the DAG talk earlier on the supply side of this, and I'm fortunate enough to be able to work very closely with Udom on a daily basis. It's been not quite 24 hours since last time I spoke with him, because we help oversee the entire budget of the DEA, as well as some of the other supply side. But also what we're doing is making sure that the President's three lines of effort, the supply of drugs, getting more treatment to individuals, it's one of the things that Ellie works on so effectively, and then prevention, as you heard talk about. We're spending more money than ever before on this issue in terms of all three lines of effort. And as a government, we're actually spending more money on treatment and prevention than we are on the supply side. It's about 52% to 48%, so it's pretty close to being even. But we understand the importance of making sure that we're preventing the next generation. You heard Ellie talk about once you become addicted, how hard it is to break that cycle and to get into long-term recovery. So directly in my office, we're overseeing a couple $100 million, a little over $100 million on drug-free community programs, 750 or so across the country, primarily targeting kids 18 and under to make sure that they are not using in going down that path. But what we're also doing is working very closely with the FDA, working very closely with the DEA to make sure that prescription is under control. And since the beginning of the administration, the president said he wants a 1/3 reduction in high-dose opioid prescriptions, and we've actually already exceeded that. We're about 35% reduction in the number of high-dose opioid prescriptions. And also, as you heard Udom talk about in terms of take-back day, is the safe disposal of drugs. And so we're working with HHS with the idea of having pharmacies and doctors give out the safe disposal bags, giving out the ability to destroy the drugs at home. And so there's a lot of ways that we can work on the prevention programs, and we work across the board on all three lines of effort.
That's a great point, because I know a lot of folks have heard about take-back days, but it's important to be able to get rid of these extra prescriptions sometimes every day. Ellie, Christina mentioned Narcan. What kinds of treatments are you seeing, including Narcan and perhaps other treatments?
Sure. So Narcan is also called naloxone. It is the opioid overdose antidote. HHS, through the Substance Abuse and Mental Health Services Administration, as well as CDC and HRSA as well, we have programs that distribute naloxone to individuals. Wow. Jim is here. What he has just handed me is nasal Narcan. This is a form that has been available not that long, in just the last couple of years. What this is a spray. So you can spray this into the nostrils of somebody who has overdosed on opioids, and it will reverse that overdose. So this is life-saving. Thank you, Jim. And it's a very important part of what HHS is doing to address the opioids crisis. I can tell you, for example, at SAMHSA, we follow the reversal of overdoses through our that happen through our grant programs, and we know that in 2019, over 10,000 overdoses were reversed using Narcan and the training that first responders receive on how to recognize an opioid overdose and then how to respond urgently to that overdose situation. But the other part of treatment is the use of evidence-based practices, and HHS has been very, very firm about insisting that evidence-based practices be used to address opioid use disorder. And what that means is there are 3 medications that are FDA approved for the treatment of opioid use disorder. They are injectable naltrexone, a long-acting opioid antagonist that's given once a month, methadone, which is a long-acting opioid medication, and buprenorphine, which is also a long-acting opioid partial agonist, so a little less potent than methadone, and because it has a better safety profile, can actually be prescribed from office-based practices. This is how we expand access to treatment by engaging primary care doctors and other healthcare professionals in providing care for opioid use disorder. We insist on medication-assisted treatment, but that's not enough. A medication is not going to solve the problem that comes with opioid use disorder, which includes a lot of negative behaviors. And to address those, we have counseling services, various types of psychosocial therapies. We also have community recovery supports because we know that for a person to recover from a condition as serious as an opioid use disorder, they're going to need help, often with housing, with peer support to make sure they stay in treatment and get the services they need, and helping them to get back to the workplace. So all of those kinds of services are brought together to address the treatment of opioid use disorder.
That's great. Katie, OJP funds so many important initiatives. Can you tell us how OJP fits into the prevention and treatment issues that we're talking about?
Yes, absolutely. Hi, everyone. So, obviously, President Trump and Attorney General Barr are laser focused on the opioid crisis. An opioid crisis, as we've heard this morning, has expanded to really now include
I think you need to press the.
substance.
Katie, could you press the microphone? Good.
But I bet you can all hear me without this. Okay. So talking about President Trump and Attorney General's laser focus to address the opioid crisis is now really a polysubstance crisis. And one of the greatest pieces of information that I have to give you is that the Office of Justice Programs' biggest substance abuse program, which is a law enforcement community-based program, opportunity, has now been expanded in the 2020 appropriations budget to include stimulants and other substances. When I traveled with the Attorney General to Montana and we met with U.S. Attorney Kurt Alme and many people in his community, and they talked about how methamphetamine was just drowning them and drowning their communities. And they have children that are being born to families that it's so multi-generational that they don't know what to do with the children. And then we have a child being raised with that kind of background and trauma. And law enforcement in many areas are the people who are responding and having to deal with this. So while HHS has a lot more money, we actually also have programs, much like Dr. McCants-Katz was discussing. We do fund naloxone to make sure that law enforcement officers in jails have naloxone. We do fund also things they might need, like masks and gloves to do pat-downs and things like that in a safe way. And then our community programming, our comprehensive community programming around substance abuse, again, expanded expanded in 2020 to include, it used to be restricted to just opioids, and now it can be programming that deals with all types of addiction. This is really an addiction crisis. Kellyanne Conway, who is coordinating the president's efforts around this addiction crisis, that's how she refers to it. This is an addiction crisis. I also want to mention and loop on to something that U.S. Attorney Herdman said, and that is, and talked about how we're reaching out to our communities. I was in Miami recently, a few days ago, heard the Attorney General speak to the IACP. And he emphasized there, and I know all the U.S. attorneys in this room, and I see so many of you, and thank you so much for all you're doing. This administration and this Attorney General sees it vital that we are actually reaching out and working with our state and locals, whether that's state and local not-for-profits, all the people in your community, really integrating our U.S. Attorney's offices into our communities to come up with real solutions. And he talked about these partnerships. So Project Relentless Pursuit is a relentless pursuit against violent crime, but so much violent crime comes from this drug addiction, from the the supply side of the drug addiction. Again, OJP is funding state and local partners to be part of those types of efforts. So the total amount last year was $333 million. And also, just briefly, I'll mention, I know I'll get to talk about it a little bit more later, is the President's Law Enforcement Commission, which Beth mentioned during my introduction. This is the Law Enforcement Commission is focusing on social problems. So yeah, naloxone is great. We need to reverse the overdose deaths. We also have to look at the toll that perhaps reviving an overdosed person multiple times, the same officer going to the same house to revive someone, the toll that is taking on our law enforcement officers. Criminal justice reform is terrific, but what effect is that having on, again, our law enforcement officers who can be put in an odd situation where they're having to learn to be social workers? And so where's the balance there? So these are some of the issues that our Law Enforcement Commission is taking up. One of my commissioners, U.S. Attorney Erica McDonald, is here, and I know many of you are involved in the working groups. Thank you, Beth.
That's a terrific point. I think we see more and more law enforcement officers having to be public health responders, and we need to think about what impact that's having. Jim, from the ONDCP side, you mentioned focusing on prevention efforts on kids who are, under 18. What other steps specifically is ONDCP taking, and what are the big projects that you're focusing on?
When we released the National Drug Control Strategy last year, and then when we reissued it again a couple of weeks ago, there's one overarching concern, and that is saving lives. And we've heard about it multiple times today, about the first time in close to 30 years that we've had a turnaround in the number of Americans dying of a drug overdose. And so in addition to making sure that naloxone, as you heard Ellie talk about, is more widely available, some of the things, for naloxone, I actually was the first government agency that required all of my 100 employees to receive naloxone training so they would have it and have the ability to save a life just in case. But what we're really doing is going much farther. We've worked on a national media campaign, the Crisis Next Door, which has had tremendous success in reaching the target audience. But really, again, we're taking a step back and looking at some of the fundamental causes of this. And with limited resources, it's down $36 billion is obviously a lot of money, but there's so many people that are being impacted by this. Making sure that we're using money to target the kids most at risk who have had an adverse childhood experience, other concerns that might lead them down that path. And so we're trying to make sure that those people are getting help. We've talked about first responders and the dangers that they encounter. We also produced out of my office, in conjunction with a bunch of other government agencies, a safe handling instruction video meant to be shown at roll call for law enforcement, so when they encounter fentanyl or what they believe to be fentanyl, that they're handling it in a safe and appropriate way. The Surgeon General, under the leadership of Secretary Alex Azar has issued advisories in making sure that people understand the prescriptions, understand naloxone. And from the White House, we put out 4 additional advisories for people that are involved in such things as the banking institution and things like that, in terms of sort of making sure that they understand when they could see sort of the equivalent of a SARS response at FinCEN. We worked with higher learning institutions and making sure that colleges understand that they need to address this issue as well. Bottom line is, part of this is stigma, that whether it's a university, when they have on their website, that we allow students in recovery, or we have naloxone on college campuses, that they don't, they're scared that parents would think about this as, my gosh, I'm not going to send my child to that school because they're worried about drug overdoses. We should think of this in terms of, hey, I should send my child there. These dorms have fire extinguishers, just in case. And we were talking earlier, Christine mentioned the illicit drugs that look like prescription pills. The way that these illicitly produced pharmaceuticals look these days, it's virtually impossible to distinguish between one that is coming from a legitimate pharmaceutical company versus a lab in Mexico. You all probably know we're having problems sometimes in requiring the manufacturers to come in, and they're looking at this under a microscope to see if they can even distinguish the ability to do this. The traffickers do have so much money. The technology that they're willing to deploy makes this harder and harder for us, for the people working on the treatment side and the prevention side, to get that foothold. We're not going to arrest our way out of this problem. I think every U.S. attorney here knows that. But we're not going to just prevent our way out. We're not going to just treat our way out. It's a combination of these 3 things working together to make sure that we achieve that bottom line of the President's vision and the Attorney General's vision of saving lives.
That's helpful. Ellie, Director Carol Jim mentioned that you could focus on college campuses as well as other things, to focus on prevention, to talk about having naloxone on campus. What steps is HHS taking in addition to some of the things that Jim mentioned?
Yeah, HHS has a very large investment in addressing the opioids crisis, and it comes from really all of our operating divisions. We have over $4.26 billion that are dedicated to the opioids crisis. The largest amount of that money would be the $1.5 billion that comes to the Substance Abuse and Mental Health Services Administration to administer to the states through a program called the State Opioid Response. This is a program that provides funding to all 50 states and the District of Columbia based on the severity of their opioids crisis. We calculate that based on opioid overdose deaths and the treatment gap. How difficult is it for individuals living in those jurisdictions to get treatment for opioid use disorder? That money goes to the states to address prevention, treatment, and community recovery resources that I talked about needing all in combination to address the opioids issue. Part of what we're doing is building an infrastructure. One of the reasons we have such a huge problem with the opioids crisis is because we weren't really ready for this kind of an epidemic of opioid addiction, in terms of treatment, in terms of use of scientifically based, evidence-based practices. So one part of this money that goes to the states is invested in technical assistance and training to clinicians in states. It's called the Opioid Response Network. And what it is it puts a team on the ground in every state of people who are clinicians within that state. They are physicians, they are addiction specialists, counselors, nurses, pharmacists, peers, individuals that can go to communities and help to address the problems that are being seen in those communities, because we know that every state is different and has different needs. And so we want clinicians from those states to be providing the services that are needed within those states. We also have a large program at NIH called Healing Communities. That's the National Institute on Drug Abuse's program of $350 million over 3 years, put in 4 states, Ohio, Kentucky, Massachusetts, and New York. And what this does is it looks at interventions to address opioid use disorders, prevention, treatment, and recovery services, looking at what works best together so that we can disseminate that to the nation. The Health Resources and Services Administration has a large program, over $400 million, that's being invested in community health services, FQHC programs, federally qualified health centers, to bring mental health services and substance use disorder services into those settings that serve individuals who often have trouble accessing services, and those in rural areas. And one of the important things that's happened through the Centers for Medicare and Medicaid Services is that it is now possible for states to get what we call an 1115 waiver. That allows them to provide Medicaid funding to inpatient services to treat those with the most severe opioid and other substance use disorders.
Christina, Ellie mentioned a few times treatment, and I think specifically medically assisted treatment, so MAT, medication-assisted treatment. So how does that work in Vermont? What's been your experience with that? And what can you tell other U.S. attorneys who are interested in this or interested in helping to make sure that people in their communities have access to this?
Yeah, sure. It's well, first off, I'll come to Vermont, but I think across the country, there's been a 41% increase in the number of addicted individuals on medically assisted treatment since 2016. So across the country, we're seeing a trend toward addicted individuals seeking medically assisted treatment, and I think it's part of the reason we've seen a reduction in overdose deaths in 14 districts in the District of Columbia in 2018, and hopefully in Vermont in 2019. But in Vermont, I think we have been one of the hardest hit states, but we do have a path-breaking treatment model in Vermont. It's called the hub and spokes model for medically assisted treatment. There are more than 9,000 Vermonters, people with substance use disorder, most of them opiate addicted, enrolled in this program in Vermont. Our Department of Health has estimated that somewhere in the neighborhood of 15,000, maybe more, maybe 20,000 people in Vermont have opioid use disorder. So if we have 9,000 people or more, last I checked, that's what the figures were, enrolled, I think that is a great sign, and I think that it shows what a critical component of our sort of holistic approach to the treatment program is. The basic model, without getting into too many details, is the hubs are these regional centers all over the state where people start their treatment. It's called high-intensity medically assisted treatment. They check in. They go to the center often. There are a lot of check-ins, and they can start on methadone, buprenorphine, or naltrexone. And of course, and this is really important, there are wraparound services provided with the medication. And that's a critical component of this. So vocational, educational, mental health, every kind of service you can imagine is being provided along with the medication. Once they've successfully completed the initial phase at the hub, they transition to a spoke, which is one of many physicians across Vermont. And there are more spokes than hubs, which can provide them with maintenance medically assisted treatment, which would be buprenorphine or naltrexone, but as well as those wraparound services, which are still very important when you get to the spoke, the clinician, and you transition out of the hub. So I think it's very successful. That being said, and this has been alluded to, we still have challenges in rural, particularly, I can speak to Vermont, we're a rural state. And we still have challenges, even though the medically assisted treatment is in every county. If you live in the Northeast Kingdom of Vermont, It can take, if you live in Essex County, Vermont, up near the Canadian border, it can take you well over an hour to get to your treatment, to get to your doctor, to get to a hub. And same with other places in Vermont. And if you are trying to hold down a job, trying to take care of your family, trying to get an education, and you have to drive that far, and you may not have a car because so many people who have substance use disorder or low income, that's still a tremendous challenge. And we're doing a lot of thinking about how to address that in Vermont. And of course, some of these people have to hold down a job as part of their court-ordered conditions. So that is something we're still thinking about and wrestling with. So definitely the medically assisted treatment is part of our holistic approach in Vermont. I think law enforcement is doing a really good job of talking to our treatment partners, knowing what they're doing while they know what we're doing, and letting them know that we would rather, in law enforcement, see addicted individuals in treatment than in jail. It's just that simple. We would rather see them take that path than have a lot of contact with us. The last thing I just wanted to mention is we are seeing a rise in meth cases in Vermont and a rise in meth seizures. I think it's true across the country. Certainly other regions are dealing with this in a much more acute way than we are, but we're seeing this problem increase in New England, Vermont and throughout New England. There is no medically assisted treatment for methamphetamine and stimulants. And as many as you know, the side effects of meth, sleeplessness, violence, paranoia, abandoning families, the health side effects, not to mention that it's deadly and can cause death. We're worried about it. Cognitive behavioral therapy and all of these wraparound services will still be available at these treatment centers, but the medication will not be. So that's something that's on our minds as well.
So MAT's been described as the gold standard for treating those who have addiction disorders, but in reducing demand, it's obviously important to educate doctors and prescribers on appropriate prescribing and pain management and in an attempt to prevent drug addiction in the first place. You heard on the first panel about how some of our U.S. attorneys and some folks in the criminal division have been going after the bad actor doctors who were really doing a lot of criminal overprescribing. But I know there are a lot of other doctors who maybe not are criminal, but are still overprescribing. And so, Eliana, as our resident physician on the panel, can you speak about the guidance that HHS has issued to the medical field?
So we have put in place a number of programs to educate physicians and other providers around safe use of opioids, safe prescribing of opioids, and how to screen for and treat opioid use disorders. One of the things that, frankly, still amazes me, and I'm a doctor, is that our schools, our health practitioner training programs, do not require a curriculum at the undergraduate level that trains on substance use disorders, and very little training is received on analgesia, how to treat pain. And so when I think about the evolution of the crisis we have now, it's really a crisis of overprescribing. And it's evolved into heroin when people could no longer afford or easily access those opioid analgesics, although that is still the major number of misusers of opioids are misusers of opioid analgesics. The important message here, though, is that when you don't get taught how to safely use these medications and how to recognize problems when they occur, then you don't, and you keep prescribing. And so the Centers for Disease Control and Prevention have published a couple of years ago, a guideline on the appropriate use of opioids in the management of chronic pain. We spend quite a bit of effort disseminating that document to providers all over the country to try to improve practice as it relates to the prescribing of opioids. We also, at the Substance Abuse and Mental Health Services Administration, have several programs that train providers on how to treat opioid and other substance use disorders. As I mentioned, we have the opioid response networks in all the states. We have technology transfer centers for substance abuse prevention, for addiction, and for mental health services in all of the 10 regions that HHS divides the country into. These provide local training and technical assistance and assistance with implementing evidence-based approaches for those practitioners and organizations that want to change their practice into one that's going to better help the people that they're seeing. We also have put out from SAMHSA something that we call the Treatment Improvement Protocol for pharmacotherapy of opioid use disorder. This actually is a blueprint not only for the use of the FDA-approved medications to treat opioid use disorder, but also these other psychosocial and community support services that people with substance use disorders need to recover. So we have a number of programs. We work with our sister agencies to get that information out not only to those that are providing addiction services, but also to primary care providers who more and more are going to be responsible for providing those services to people. I also want to say just something about the methamphetamine issue because we've been watching our data. One of the other things that we do at HHS is we have a number of different surveillance systems to look at what's happening with substance misuse and abuse in this country. And so we have seen for some time now, for about the past year, we've been looking at increases. SAMHSA has something called the Drug Abuse Warning Network that tells us what's being seen in emergency departments in terms of toxicities related to misuse of illicit substances. And by far and away, I can tell you, methamphetamine is the major substance that is bringing people to the EDs for urgent medical care. We don't have a medication for it. We know this is a problem that's going to emerge and continue to be really quite problematic, particularly with opioids. And so at HHS, we are already working with the states. We had a 50-state meeting last summer to talk to state officials and to providers about how to recognize and treat methamphetamine and other stimulant use disorders. And we also are talking with them about the kinds of psychosocial interventions that are best used. Methamphetamine is a difficult drug. Because there's no medication and because it has effects on the brain that really affect somebody's, their cognitive function, their ability to think clearly, their memory, their ability to concentrate, it's difficult to get them engaged in those psychosocial services early on in treatment. And so we have some alternatives that can be engaging to people, such as contingency management, which reinforces positive behaviors. And so we're looking at those kinds of interventions and working with the states around how they can allow those sorts of interventions to be used to make that engagement and to keep those folks in treatment long enough to where they can get to where they can use other kinds of interventions like cognitive behavioral therapy, which teaches them different coping skills.
That's a great point. Jim, how is ONDCP working to reduce overprescribing, and what are you doing, as Ellie said, to kind of focus on some of these emerging meth issues?
What we're doing is we're starting at the core, and we are talking to medical schools. I spoke at the National Association of Medical Colleges, trying to get it into their curriculum when the kids are in medical school to make sure that they understand the dangers of this. It's interesting. One of the most frequent death threats I get are from people who have chronic pain. I think Ellie's probably in this group too, of people who have chronic pain and think that we're trying to either stigmatize them for taking opioids or take away their life-saving pain pills. And clearly that's not what we're doing. Udom, Dylan and I are working on an op-ed with HHS, with Brett Jawar, the Assistant Secretary for Health, to go out to make sure that prescribers understand we're not targeting individuals who have chronic pain. We're not targeting physicians who are treating those patients. We're going after the illegal actors. And so what we're trying to do is to make sure that people understand that we're only reaching out to those individuals to make sure that they understand they only need enough to get by. that if you break your arm, it's going to hurt, and that you shouldn't feel, it's okay to have a little bit of pain associated with it. I was at Walter Reed Hospital earlier this week, the end of last week, and it's really phenomenal to see some of the work they're doing with these wounded warriors who have lost a limb or two, or in the case of one soldier I met who had lost 3 limbs. And in looking towards non-pharmacological responses to help them, and to make sure, they're getting such things as acupuncture. They're getting a wide variety of treatment. And for folks outside, the Walter Reed system, outside even the VA system, is to make sure that there's reimbursement for individuals who are seeking alternatives to a traditional pain treatment protocol of opioids. In terms of the treatment that is out there, one of the things that I really want to highlight that in working with HHS that they did was a website for findtreatment.com that anyone can go to. It's completely anonymous. You put in the zip code, you can find the gold standard state licensed facilities that provide treatment to individuals. There's all sorts of drop-down menus. If you have insurance, if you don't, they can go to the Find Treatment website and get help. We're desperately trying to work on that side of it so we can cut down on the supply. Uda mentioned 90% of heroin coming from Mexico. As you all know, how many folks have either a rising or already overtaken methamphetamine problem in your districts? Yeah, it's, you can see it. Probably half the room, Beth. Again, it's simple on the statistics side for Udom and I to talk about, because 90% of methamphetamine is coming across the southwest border from Mexico. 90% of the cocaine in the U.S. is coming from Colombia. But the Find Treatment website, the ability to reach people who have an addiction crisis, it's really not just an opioid addiction. They have an addiction issue. And opioids might be the drug of choice today for them. It might be methamphetamine tomorrow, or cocaine the day after. Or what we're really seeing is polydrug use as well. That's different back 30 years ago when I was a state drug prosecutor. So if we can get more people into treatment, if we can prevent more people, it gives the opportunity for you all to really work on the supply side.
Katie, Christina talked about the difficulty of getting treatment to folks, especially in rural communities. In light of all the interagency work to prevent and treat drug abuse, how is OJP specifically working with communities to reduce demand, and especially rural and tribal communities?
Thank you very much, Beth. And one thing that I think most people in this room know is the Attorney General Barr's commitment to making sure that resources are distributed to our underserved communities, and in particularly rural and tribal communities, and his commitment to that. So we will be prioritizing rural and tribal communities. I really want to congratulate U.S. Attorney Nolan. The stuff that you're doing in your district is fantastic, exactly the kind of collaboration between state, local, and behavioral health programming that we do fund. And so that's very, I'm so glad to hear that. Sometimes I was raised in a rural community, I was a judge in a rural community, and I know how scrappy and creative you have to be in order to help the people who need help. And we know how much this addiction crisis has hit our rural communities. So there is an emphasis there in the Office of Justice Program grants for 2020. I also want to talk about reentry programming. Obviously, with criminal justice reform, President Trump's focus on the First Step Act, the new executive director of the Interagency Council on Reentry just started with me at the Office of Justice Programs. Tony Loudon is here. He's going to be working hand in hand with the White House from my office to look at reentry program, what's working, what isn't. We have a lot of funding for reentry. And of course, having been a judge that implemented and ran a drug court, I know how much our problem-solving courts are key to helping this crisis. As U.S. Attorney Nolan said, we want people not to be incarcerated, but to be rehabilitated. That's better for public safety, that's better for communities, that's better for individuals. So that's what we want. Problem-solving courts, drug courts, which again, we have a separate pot of funding for, are a key part to meeting that goal. We also fund medically assisted treatment in jails. So obviously, as Dr. McCann's Katz being a leader in making sure that everyone is educated on that, and obviously has a lot more funding than I do, but we are funding medically assisted treatment in jails and a lot of technical assistance. So we're also training people in communities in how to most effectively, with evidence-based and best practices, help to combat and come together in a collaborative fashion and use all the resources that are available, whether that comes from ONDCP, HHS, or the Office of Justice Programs, to help these people and to reverse the trend of this crisis.
So focusing on law enforcement for a moment, Christina, how do your efforts and the efforts of your fellow U.S. attorneys support the effort on prevention and treatment? You talked about the hub and spokes.
Yeah, so I think law enforcement plays a key role in supporting, not just in supporting prevention and treatment efforts, but in taking our own initiative. May I talk about the District of Vermont program? So we have a prevention program in Vermont now that's centered around a documentary called Face of Recovery, and a related public service announcement. The documentary is 9 minutes. The public service announcement is 60 seconds. You can find them on our website. If you go to the Face of Recovery banner on the right side of the website. The documentary tells the story, the success story of a former defendant in our office who I actually prosecuted in 2011 for drug trafficking and gun crime, very serious crimes. He's gone on to make an incredible recovery, and the documentary tells his story, and he and I are going to schools, recovery centers, anyone who will listen in Vermont to show this film and then answer questions and kind of give our perspective. But the reason we wanted to do it, well, there's a few reasons, but one is we want to tell success stories, right? And we want to give people hope. There is so much sadness and so much tragedy in this crisis, and it's real, and I'm not suggesting we turn a blind eye to it, but there are success stories. There are people who are overcoming addiction, like Justin Goulet, who is the subject of this documentary. He's, by the way, speaking on Friday, so I commend that panel to you. And the success stories, I think, can inspire all of the stakeholders in this holistic, multidisciplinary approach that we're talking about. So hearing these success stories inspires prosecutors to keep fighting, and treatment providers, and people in the prevention and recovery communities. The other thing, and I cannot tell you how much traction this presentation is getting with kids. We've taken this to a few schools, and we have more lined up. And the administrators have to cut off the question and answer period. I mean, they're sitting in the bleachers, and there's 20 hands up still, and we have to stop talking. But I think he's really resonating with kids. The other thing I think that this does, and a reason it's important that law enforcement is involved in these efforts, is it promotes public trust in law enforcement. Not that they shouldn't trust law enforcement. I'm obviously a huge supporter, and think that there's some misguided distrust. But this does promote public trust because it shows people that law enforcement wants you to have if you're an addicted individual, we want you to have your life back. And we want to get to young people and people who young people who are thinking of using or other would-be users. We want to get to them before the drugs do, and we don't want your story to end in arrest. We don't want anybody's story to end in arrest. And so that's a project, that's our prevention project in a nutshell in Vermont. But there are a number of amazing law enforcement initiatives. The DEA administrator talked about the DEA Take Back program. I think in April 2019, 469 tons of prescription drugs were taken back. Too bad we don't know how many lives that saved, but I bet it saved some lives. And there are other great programs. Rob Duncan's, where's Rob? Hey, Rob. His program in the Eastern District of Kentucky called USA Heat, which I've seen presentations on, involves families who've had loved ones who've passed away from opioid overdose or other overdose, going and talking to audiences and coming at the prevention angle that way. So we have a role to play. I encourage us to take initiative. I think there are so many benefits to us being involved in prevention.
That's great. So Jim, I just want to talk for a minute about naloxone. I know you carry it around in your pocket. And,
This is a pretty dangerous crowd. I wasn't really sure.
Yeah.
So.
And I know it's not a cure-all to everything, but can you talk about what efforts have been made by the administration to really increase the availability?
Yeah, really what we're trying to do is to make sure that people understand that they should think of it as a fire extinguisher. They should think about it just as a what if. There's several thousand law enforcement, state and local law enforcement departments now that all of them carry it. We're making sure that there's enough supply coming forward in that supply chain so they can constantly have it. You know, in West Virginia, in Oklahoma, Tim Downing from Oklahoma was here. I was talking to him for a few minutes in the hallway. When, you know, I was in downtown Oklahoma City. I did a ride along in Baltimore, which was interesting. And you do see the, I saw naloxone reverse someone and save their life. And there's a little bit of stigma with it, right? And some people have the thought that, oh, if we give them naloxone, all we're doing is enabling them. The reality is we are saving their life, but what we're doing is giving them that opportunity to get treatment, getting them one more day so we can have the opportunity so they're not contributing to the oversupply, and more importantly, they're not losing their life over it. And so it's one of those things that we encourage, the president encourages, Ellie encourages, everyone encourages, and as well as you all, because it does have the opportunity to save a life. And so by making it more widely available, by talking about it, by most states now, probably all 50 states I think at this point, have standing orders so anyone can walk in to a pharmacy and get it without your own doctor's prescription because the state has allowed it. And so it's the opportunity to get there. One of the things that Christina mentioned I think is important also, if I can just flip back. So many of you are, not just Tim in Oklahoma or Rob a little bit farther south from here, do have rural communities. And I never thought that I would be working with the FCC in this role as the drug czar, but we're working with the FCC to increase broadband access to make sure that we can reach people. There are some rural parts of Vermont as well, and we released a rural resource treatment guide to make sure that people in rural communities have the ways to find treatment, have the ways to get resources. Ellie was instrumental in working on this to make sure that we're trying to reach people regardless of where they are, even if they have access problems, even if they have transportation issues to get treatment, is making sure that they can get the naloxone, they can get MAT, they can engage in telemedicine, and we can use the technology for good instead of the evil that J-code targets.
That's great. And Katie, I'll end with you. Katie is the most popular component head because she gives out all the grants, and so I will ask the question that probably everyone is wondering, which is, how does OJP assist U.S. attorneys and their state, local, and tribal law enforcement partners in this mission of treatment and prevention?
Thanks, Beth. I thought I was the favorite because of my winning personality, but I guess it's not. I'm kidding. All right. Look, we're here to help you. We really are. I think one of the things that we have done, at least in my tenure, which was June 17th of 2019 is when I took over running OJP. One of my very first efforts was to start to make sure that OJP was engaging with U.S. attorneys' offices. And we have attempted to do that. We're trying to roll out much more external-facing documents and public-facing announcements that you all can make. I think the Attorney General, again, to go back to his priority, which is that we work shoulder to shoulder, that federal and state and locals are working shoulder to shoulder to combat the issues in your community, the opioid addiction, our addiction epidemic being forefront and priority for both President Trump and Attorney General Barr. The Office of Justice Programs truly is here to help you. And I know that some of that is just education. When I travel, I make sure to try to make a meeting with either you guys, the U.S. attorneys, or your first assistant, so you can ask any questions that you might need. The President's Law Enforcement Commission is such an important vehicle for U.S. attorneys to have a voice. We will be making recommendations to the President, the first commission since 1968. This is the President who put the commission together, understanding that our law enforcement officers are facing unique challenges, including the social problems that we're talking about today. It is incumbent upon us to provide recommendations to the President to help support law enforcement, to help our communities. So please stay involved. I thank you all so much. And anything that you need from the Office of Justice Programs, don't hesitate to reach out. Thank you.
Well, thank you so much. Thank you to all of our panelists for their commitment to fighting this epidemic, and thank you to all of you for being here.
And again, thank you to all these experts that served on our panel. I think all of their insight into this area was really helpful. Thank you to Beth and also to OLP who helped put this panel together. At this time, we're going to break for an early lunch. Thank you for participating in this morning's session. For the registered DOJ participants, we will be resuming after lunch in your assigned rooms promptly at 12:45. Please note that the Attorney General entrance that many of you came through this morning will be open from 12:15 to 12:45 for re-entry again. Thank you and enjoy your lunch.